a PDF. And let's see, I think that's all of my housekeeping. But again, my name's Andrea. I'm with the Parkinson Movement Disorder Alliance. We're the nonprofit hosting today's session, and we're so glad you joined us, and so grateful to our movement disorder neurologist, facilitator, and our expert guest. So Dr. Subramanian, I'll turn it over to you to tell us about who we have joining us today.
Great. Well, thanks so much for joining, everyone. Great to see everyone out there in virtual land of support groups. And, you know, we're still physically distant here, but socially connecting and virtually connecting. And thanks to the PMD Alliance for hosting this. And I took a little break. I actually traveled to our beautiful, around our beautiful country, which I don't get to do so much because I love to internationally travel and feel a bit rejuvenated and refreshed. And, you know, just getting out in nature a little bit is just really spectacular. And so hopefully you guys can do that safely wherever you live. I would definitely encourage, you know, getting out in the sunshine if you're somewhere warm. And so awesome to see the world and, you know, the beauty in it. And so excited to have all of these folks joining us from literally all over the world. It's really exciting. So it's with great pleasure that I bring my friend and colleague to you today. Hubert Fernandez, who's just a force of nature. He's been amazing. He's just, if you look up his CV, he's studied so many important topics out there in the world of Parkinson's patients and their caregivers, and he really cares about patients so much. He is the director at the Center for Neurological Restoration. That in and of itself is a super cool title that Hubert will have to tell us a little bit about. He's at the Cleveland Clinic now. He spent some time with our friend Mike Oken at the University of Florida, who tweeted out about this presentation and said, Hubert is the king of clinical trials and knows everything about Parkinson's, is what Mike wrote on his tweet. So you come highly recommended, Hubert, from your own colleagues there. Hubert trained in Boston at the Boston University for neurology residency, and then trained at Brown for his fellowship in movement disorders, and has led the world in many ways in Parkinson's, and has traveled internationally. We hope to learn a little bit about some of the work that you've done in the Philippines as well, Hubert, later on. But I'll pass it on to you to teach us a little bit maybe about your journey, why you chose medicine and neurology, and then how you became interested in Parkinson's and kind of what you've been doing in that world. And then I know you have a slide presentation, and maybe you can segue.
Yeah. Yeah, sure. Let me, should I start sharing my screen while
You can tell us a little bit maybe about yourself and how you got there, and then you can share your screen in a minute.
Yeah, so yeah, sure. So yeah, I was born and raised in the Philippines, and I did all of my postgraduate kind of education here in the United States, and was kind of ready to go back home until actually my wife and I were ready to go back home, and then our bosses, I guess, liked us quite a bit, and so they paid for our lawyers. We're very grateful for both our bosses. And so I stayed at Brown and she stayed at Harvard, and we lived there until we got a call from Mike Oken to join the University of Florida. And then we were there for 7 years until we got a call from the Cleveland Clinic. And so hopefully we don't get any more calls. And we plant our roots here at the clinic. It's just a wonderful place to be, especially for it has some, you know, like anything, good and bad parts. But the really good part about it is that it takes patient care to the next level. And if that's your thing, that, you know, that's what drives you as a clinician, I can't think of a better place. Of course, everyone can say that in their institution, but I just love where I am right now. Medicine was actually my 5th choice as a career. I wanted to be a high school teacher first because I just loved my high school teachers, and I thought they were great role models. And then my dad said, there's no way you're going to feed your family as a high school teacher in the Philippines. This is in the Philippines. So I said, okay, I'll be a concert pianist. And then he said, no, if you want to be a piano teacher, then yeah, no, I want to be a concert pianist. Like only the 1% become concert pianists, which is true. And so he said no, and okay, I want to be an architect. And he said, that's not a bad occupation, but we have no pedigree in architecture. So you're going to be making storage boxes. Um, and so I chickened out and I said, I want to be a lawyer. Well, if you want to get shot, you could be a lawyer in the Philippines. So I said, okay, so maybe medicine. I said, and he said, okay, great choice. Um, so and the rest is history. And I'm very thankful that he actually forced me into this. The studying was a little difficult because it was my fifth choice, but now that I'm a doctor, I can't imagine anything other than being here with you guys and treating my Parkinson patients and all. So, yep,
Well, we're
that's my
grateful.
long-winded story.
Grateful to have you. So, Hubert, why don't you teach us a little bit about the non-pharmacological ways to help
Sure.
Parkinson's? You can share your screen now, and then we'll take some question and answer and learn a little bit more about your work as well in the Philippines.
Yeah, my pleasure. Share. Okay, can you guys see this?
Perfect.
Awesome, and you can hear me okay?
Perfect.
So I thought that, when Indu said, you can talk about anything you want, it's actually kind of a difficult order in a way because I want to talk about so many things. And I actually can, she knows I'm a talker, so I could keep talking all day and it won't run out. But I wanted to share something really practical for you guys. And this virtual platform with colleagues we're used to virtual platform with patients where I'm not quite used to yet. So I wanted to make sure that this is something that was as entertaining as it is as useful. It's not too heavy, but it's also relevant. And so I'm going to do this, non-pharmacological therapies of Parkinson's disease. The background is of the Cleveland Clinic. This is where I work. This is the picture on the one day of the year that it's not snowing or raining. So um, uh, you're all welcome to visit us should you care to get a second opinion or just visit our wonderful museums and restaurants. Okay, now it doesn't seem to be moving. Okay, so why non-pharmacological? I could talk about so many drugs. Michael Oken said, I know a bit about clinical trials, why not that? Well, this is kind of near and dear to us, to Indu, to me, who are, colleagues who are really into patient care. Because as you can see here, we have so many things that we need to talk about in, a half an hour visit with our patients. We have lots of oral medications. Then we have the surgical therapies. And it doesn't even end there. We have the non-pharmacological therapies, PT, OT, speech, swallowing, exercise, and then all the education that needs to be done. And, if we have to talk about all of this in the half an hour of office visit, and in some cases it's 20 minutes, 15 minutes, depending on what the setup is, we're going to run out of time, right? And so the reality here is that when we see our doctors, the most 80% of what they're going to talk about is really oral therapies. One, because we're all about drugs. This is what we're trained to do. And we just run out of time for everything else. Surgical therapies, non-pharmacological therapies, and education and counseling. And so I wanted to give justice and spend more time on the things that we don't talk about a lot in the office visit. There are several challenges in Parkinson's disease. So one of the challenge in Parkinson's disease is, unfortunately, it is a disorder that affects nearly every organ system in the body. So we know when I ask people to close their eyes and imagine someone with Parkinson's disease, you would be imagining someone with resting tremor, with stiffness, with slowness. These are the classic motor features of Parkinson's. But we know the Parkinson patients here in this webinar, they're a testament to the fact that that's only the tip of the iceberg. We have the GI system, the genitourinary system, the mental and behavioral part, balance problems, and all the rest, that all the other systems that are involved in a cluster of endless symptoms in Parkinson's disease. And so fitting that in the office visit is a challenge. And then it doesn't even stop there. The bigger challenge is even bigger challenge that is every patient with Parkinson's is unique. So these are three names that I invented, Amy, Brad, and Charlie. So for Amy, it's the motor features and the genitourinary symptoms that are really predominant. For Brad, it's everything else. For Charlie, it's a bit more balance, and it's the mental issues and stuff like that. And so one, you need to know all these symptoms, all these clusters and systems that go along with it. And then you have to figure out which is more involved in one patient or another, and then fit them all in with your oral and non-pharmacological therapy. It's nearly an impossible task to kind of help out the patients in a most wholesome manner. So I did a simple experiment. This is not the most scientific one. It's just a survey of the first 100 patients who come into my clinic. And I just asked them, I'm giving this talk on non-pharmacological therapies in Parkinson's disease. What would you say is the single most useful or helpful non-pharmacological tip or advice or treatment that you have received, not only from me, but from anyone else in your Parkinson journey? What would this be? And then I just jotted them down, and with the computer nowadays, I made that into a word cloud. I don't know if you know what the word, how to do this. It's very easy. You Google word cloud, and then basically you type in all the responses, and the more and more response on that same item is, the bigger the word cloud becomes. So this is all we group them all together, we summarize them, we put them in the word cloud, and this is what I got. And as you can see, there are helpful tips that are resonating a lot more than others. And I'd like to take a closer look into this. So let's take a closer look. As you can see, a lot of patients, look at the ones that I'm underlining right now: walk sideways, walking sticks, boxing, stationary bike, exercise, keep moving, Tai Chi, walking, cane with a laser, running. And so what is this telling me? What is the overwhelming, most valuable tip that Parkinson patients get from their providers? That they all want to move, that mobility is king. So over all the problems that we need to improve in Parkinson's, they also want education, they want to improve apathy, they want to improve their fluctuations, their posture, they want to talk better, they want to move their bowels smoother. But the most important thing of them all, overwhelmingly, is that they are thankful that they're able to move, that this tip, one way or another, made them move better. And so that they thought was the most important thing. And it's for good reason. So I'm going to present some science that goes along with it. So it is clear now that the effects of physical fitness goes beyond just fitness itself. It really goes, it touches a lot of kind of our healthcare outcomes. So this is one study of elderly patients from 70 to 90 years old. And they basically were asked to walk a quarter of a mile. And then they were divided, depending on how fast they walked, the fastest and the slowest. The first quartile, they were divided into four quartiles, basically. And then you have Q1 as the fastest and Q4 as the slowest. And you can see here, those that walked the fastest, that had the most physical fitness, had the least amount of, so this is the Q1 with regards to their mobility. So I have my, so this is the fastest, and then the Q4, the blue one, is the slowest. And you can see, the faster you are, the less likely they were going to die, and the less likely they were going to have a heart attack. So just a very simple but very elegant study on this. So regarding Parkinson's disease, balance is kind of a big issue for us. And then the most that prevents mobility. And then the biggest evidence base we have is on yoga, Tai Chi, and dancing. So if you have mobility issues, in particular balance, and you want to do something about it, Tai Chi and yoga and maybe dancing, if you could do it in a steady manner, would be good. So here is one study I really published at the New England Journal of Medicine and also in movement disorders. This is a 6-month intervention of nearly 200 patients, and they were basically asked to do Tai Chi or the equivalent resistance or stretch training 1 hour twice a week. And you could see here, look at this, the benefit. Tai Chi wins over resistance in all these, in a lot of, not all, but in a lot of measures of kind of walking and balance. So direction of control, you know what that means. Stride length is how big the stride is. The speed of the walking, the ability to reach, the leg strength. This is the Parkinson motor score, and then the number of falls. So Tai Chi beats resistance in not all, but a lot of things, like their direction, their stride is better, and then the number of falls is much less in Tai Chi compared to resistance. Now, with regards to stretch, Tai Chi versus stretching, if you think Tai Chi is just about, it's just glamorized stretching, it may be, but look at this, it wins about pretty much in all areas that has something to do with walking and with balance. So I'm a big advocate of Tai Chi, and we have evidence for it. So this kind of, I want, you know, Indu and I, we share this common love for traveling. There is so much about our planet to explore. We just love them. And I was asked to give a talk in China, and the place was, you know, Hangzhou or Hangzhou, China. And they have this beautiful lake. It's called the West Lake. I'm sure it has a Chinese name. And I'm not an early bird, but this one, every single day that I was there, I woke up at 5:30 a.m., mainly so that I can walk around the West Lake and see all these groups of elderly and some not so elderly individuals grouped, organized into their fitness of choice. And they would do this from 5:30 up to 9 a.m. And so there would be there's this class on ballroom dancing. This is the one with the pergola. They're dancing, ballroom dancing. This is the Tai Chi group. There's a karate group. There is a hip hop group. It's just amazing. This country has very low rates of obesity, high rates of longevity, and I think it's in large part they have bicycles all over instead of cars, and they take advantage of nature and the things that they love to do. Life is a slower paced, and they meditate a lot, and they do a lot of these things. So that's my first lesson. The second lesson, if you look at this, some of the tips that I got from patients that they found very useful: walking sideways, walking using sticks, using a cane with a laser, or running. I think they were trying to tell us that overcoming freezing is really important. And what you gave us as a tip or an advice to overcome freezing really we found very useful. So this is a patient that, a Parkinson patient that I'd like to share. This is something that
if you could cross your hands across your chest and then try to stand up.
Them a lot.
Very good. Arms down. Now I'd like you to start walking out the door.
So see, he gets stuck at the initial stage of the walk. We call that gait ignition failure.
Okay, just try your best.
And shuffles a little bit and then he freezes. The next part of the freezing would be approaching the door. As you reach a threshold there, he freezes. So
and then just go straight.
Second common one. When they reach threshold. And then it gets a little bit better with walking. That's kind of a normal thing. And then with turning, it shows
up. Turn around.
Again, there you go. We call that turning en bloc. So I wanted to showcase this for people who aren't used to the word freezing, that this is what we talk about in Parkinson's. We say, I'm freezing, he's freezing. It's not because they're cold, but more because their foot is stuck on the ground. And then the second, for those Parkinson patients that are watching this and they're freezing, this is to kind of share with you that where you freeze that irritates you a lot, which is when you turn, when you reach a threshold, when you start your gait, you're not alone. I mean, this is what I see in nearly every patient who freezes. Those are the three most difficult spots that we can do. I'm sorry, that they experience. So, overcoming freezing. So there are many ways in overcoming freezing. Unfortunately, the drugs are a hit or miss. If the freezing occurs in the off state, when the medication is not working, then that can be overcome by medications, because what we need to do is make the medications connect better from dose to dose, or alleviate the wearing off, and the freezing would get better. But if the freezing occurs at any time during the day with no relation to the medication, that's a bit harder, and they may not respond to the medications very well. And so sometimes, surprisingly, if they run at a somewhat faster pace, they unfreeze. They rely on auditory or visual cues to kind of overcome their freezing. So walking with a cane, with a laser, and then making their foot step over the line of the laser is an example of a visual cue. And then sometimes try this. If you can't walk forward, try walking sideways. You're still going to get to your destination, except that maybe it looks a little funny, but you're going to get to your destination if you walk sideways. So try that. So we have a lot of these visual cues. So this one is putting markers on areas where they get stuck, so they can use that. You step over the line or step on the line. And then when, for stairs, you can see here, you just, step over the circles, different colors. This is an exercise to kind of unfreeze you. This is a usual technique of a cane with a line there so that you could make the patient kind of step over that and to help them unfreeze. And then the more sophisticated one, you use laser technology, you clip it on the foot, the shoe, I'm sorry, and it automatically makes a line in front of the patient with Parkinson's, and then they try to kind of step over that line. And then when their foot is on the ground, there's another new line, and then they just step over that. So these are just some techniques that we have, creatively advised patients in kind of overcoming their freezing. Lesson number 3, that I wanted to share is very similar to mobility. Here, best advice we've given, several on boxing, a lot on the stationary bike, some on yoga, some on Tai Chi. So really, exercise, what they're saying is exercise is key. And we're really glad that this finally took on, because Parkinson's, we weren't the first group of the first subspecialty to kind of embrace exercise. But in, I forget when, 2006, so almost a decade and a half ago, there was this large a study of nearly 2,000 adults, elderly adults from Seattle. And they looked at, basically, they just looked at, of these 1,700 individuals, they grouped them into two, basically. Those who exercised rather vigorously, which is 3 or more times per week, 45 minutes at a time, versus who had less than that, less than 3 and less than 45 minutes each day. Those, regardless of, this is just healthy adults. Some of them may have Parkinson's, some of them may have Alzheimer's, whatever it is. Just they took all comers, but generally healthy adults. And just the fact of exercising 3 days a week, 45 minutes each day, patients on that group were 40% less likely to be diagnosed with dementia, with Alzheimer's disease, compared to those who were a bit more sedentary. So the Alzheimer's world picked it up quicker than the Parkinson world. And so it spread like fire. Everyone was like hyping exercise, which is great. And the problem with Parkinson's disease is, it's a little bit harder to do. Until we finally had animal models where exercise was showing some potential. So this is an example of a mice, kind of mice to rat, I think these are mice, study. This 6-OHDA, that is a kind of a toxic substance that we inject in the brain of mice, and that gives them, quote unquote, Parkinson's disease, artificial Parkinson's disease, or Parkinsonism. It's not, the same. It's almost the same as the Parkinson's we get, but it's the only way we could do it in mice. So in this study, and then see here, we tilt the thing and we put a treadmill and we tilt it so that they have to kind of keep working so as not to fall behind. So that's another way of doing it. We have to, or we need to, in this case here, the treadmill is just running on its own and they just have to keep up, because we can't make the mice just, exercise without doing anything. So in mice, so the mice were given the toxic substance, and then half the mice were forced to do exercise and the other half were just to do whatever you want to do. And then they were tested in 7 days, 14 days, 21 days. And then they were unfortunately euthanized. And then we looked at their brains. So not only did the mice who were on the treadmill did better on all the testing in a week, in 2 weeks, and 3 weeks, but when we looked at their brain, there was hardly any trace of Parkinson's, even if they got the toxic substance. Whereas those who who were randomized to normal activity showed full-blown the scars of Parkinson's disease. So there was nearly a 90% protection from Parkinson's disease that exercise did. It's just amazing. And then in humans, of course, it works, but not as dramatic as the mice, right? It's not as, like, that's 90% and so dramatic in mice. And then in humans, yeah, they got a little bit better, and better is a little bit is better than nothing, but it's not as dramatic as mice. Until our scientist, biomedical engineer, and exercise guru here at the Cleveland Clinic, Jay Alberts. He had his aha moment in the cornfields of Iowa. So he was, he's spent his research and translational research career in Parkinson's disease. And so he kind of organized this Iowa bike ride for Parkinson's disease patients as a cause, the fundraising for Parkinson awareness. And it caught fire, and the Parkinson patients wanted to join. Well, this is for us, so we want to join you in. And a lot of them are kind of rather fit, and they wanted to join. But Jay Alberts and his crew, these are, yes, translational scientists and all, but they were fit translational scientists. So they were near professional bikers. But they wanted to entertain the Parkinson patients, include them in the cause, which is for them. And so they created these they got these tandem bikes. And so the professional biker is here, and then the Parkinson patient is the one kind of trailing behind. And so most of the work is on the professional biker. So like this, and then these are the kids, I guess. And then these would be long distance kind of exercises. And they would have pit stops in various cities or wherever, towns. And then when they had the pit stop, he heard from the Parkinson patients that were in the second seat in the back of the tandem bikes that their Parkinson's they're feeling better with their Parkinson's. They're shaking less for whatever reason, and they're looser and they're quicker. And this is the aha moment for Jay Alberts. He said, so that's the trick. This is why the animals are doing so well in the experiment. Sorry. Of course, they always get a page whenever when I'm giving a presentation. So the reason is not really exercise. Of course, exercise is beneficial. But in mice, if you'll notice, the treadmill had to be turned on at a certain speed for the mice to work. Otherwise, it wouldn't work, right? So we were forcing the mice to exercise, not at their own pace, but at the pace of the machine. And so here in the Iowa bike rides, it's almost the same as forcing the patient trailing behind to keep up with the professional in front of the tandem bike. So if the exercise was, so this is when he thought, well, if the exercise then was high speed, low resistance, so that all that the patient needs to do is keep up with the pace. They don't need to work harder, but rather than to keep up with the pace, maybe that'll be an effective exercise over just walk briskly on your own or do the treadmill or do the elliptical machine. They're still good. Don't get me wrong. They're still better than doing nothing. But if we set up a certain pace and we make them keep up with that, would that be better than regular exercise that we know of? So we then did the clinical trial of forced exercise versus voluntary exercise. So it's very easy intervention. It's 2 months, once a week session for 2 months. And each group would have 10 minutes of warm up, 40 minutes of exercise, and 10 minutes of cool down. So the 10 minutes of warm up and cool down is the same, whether you get forced or voluntary, but the 40 minutes of main exercise has to be either forced in one group, meaning the pace is set, and then voluntary for the other group. You could run fast or slow or whatever, just do whatever you can. But so that it's not effort dependent, the target heart rate for either group has to be 60 to 80% of their heart rate. So your heart has to be, pumping faster. So, but voluntary exercise, you do whatever you need to do to pump your heart faster. Whereas for the forced exercise, we're going to put the pace for you, and all you have to do is keep up with it. And they realized that they found out that the forced exercise group actually pedaled 30% faster than those who were on the voluntary exercise, but they had 42% less work compared to the voluntary exercise. It's just unbelievable. So the forced exercise people were just keeping up with the one in front, whereas the voluntary, they just had a free bike, pedal as whatever you want to do just to make the heart rate go faster. And so they were pedaling 30% less and they were working 40% more in the voluntary exercise group. And so what did we find out for the result? Regarding fitness, this is the fitness. This is VO2, which is a measure of fitness. They were equal. I mean, there's a little bit, this is the forced and this is the voluntary. So it looks like the forced is a bit more fitter, but statistically there was no difference. But look at the Parkinson motor score. For the motor score, the higher the score, the worse the patient is motorically. And EOT means end of treatment. And you can see the forced exercise, the paced exercise, was 35%, had better motor scores than those with voluntary exercise. And then they were told to stop exercising, just go on with your life, and let's measure it again 2 weeks after the exercise. And look at this. The forced exercise group maintained the low level, the good low motor impairment. And after a month of not exercising, still, those who got the forced exercise still did better than voluntary exercise. So this is a big moment for us at the clinic. And it is shared by a lot of other studies. It's not just us. So this is one study comparing aerobic exercises versus stretch. So definitely aerobic is better than resistance. As you can see here, the aerobic did better. You just have to trust me on these scores. The blue is always, the red had better scores than the blue. So that's just how it is. And so the worst is nothing. A little bit better is resistance training. Even better is aerobic training. And even better than that is forced paced aerobic training. So that's how we do it. Now, the problem with these Parkinson exercise trials is you kind of know, it's unlike drugs. So it's easier for us for drugs. And I'm a clinical trialist. I'm all about drugs. Dr. Subramanian knows about this as well. When we test a drug for Parkinson's, we do it double-blind, placebo-controlled, right? So a group gets the real drug and the other group gets a sugar pill. And we're trying to see whether those who got the real drug do better than those who got the sugar pill. In exercise, you kind of know, okay, you're going to be staying fit and you're going to exercise every day. And then, you just be a couch potato, you just go on your own. Just do whatever you're doing to make you happy. So you obviously know what assignment you have because you're being told to exercise a certain way. And of course, those who are exercising, who got the group of good exercise, they want to show that they got better. And so there is a lot of bias. So to the rescue is these what we call functional MRI or functional imaging. So they don't look at just the anatomy, but they look at the brain uptake, and they look at how whether there are regions of the brain that are becoming more active than usual. So this is an example of pre-exercise. This is where, before you exercise, this is where blood flow goes into, concentrates in the brain of a Parkinson patient. And look, post-exercise, there are newer regions that are being more activated and receiving more blood flow. So this is now, you can't force yourself to, put in some more blood in this region in the middle. So this is really what's happening to Parkinson brains. And believe it or not, this is nearly identical blood flow and uptake imaging off medication versus on levodopa medication. So what exercise is doing is, in a more natural way, approximating or inducing the blood flow and activity levels in the brain that drugs would have done. And so that, which is one reason why it may be working. So there are more things about exercise and more imaging studies now showing, difference in blood flow and uptake patterns in the brain before and after exercise. Okay, so from the cornfields of Iowa, with a tandem bike, we did the clinical trial. We showed, I told you, persistence of improvement in motor scores even 2 weeks after the study is over, even 1 month after the study is over. And now it is part of our day-to-day care. Every single Cleveland Clinic patient gets a prescription, unless they can't because of their heart or because maybe their legs were cut off or whatever it is. But they get a prescription for exercise and a stationary bike. And what we do is our prescription, I'm going to share with you our secret, is we tell them to get a bike. It doesn't have to be the tandem, doesn't have to be something really expensive, doesn't have to be Peloton, but if you can afford it, that's great. But get a bike with a speedometer and a odometer in there. And the first thing you need to do is lower the resistance down to level 0 or level 1, as light as a feather. Make it very easy. And then the patients who did the best in our clinical trial are those who reach 90 RPMs, revolutions per minute. Depending on your fitness level, that may be easy enough, or that may be nearly impossible, or that might be a little more difficult. So if you can't reach 90 RPMs for 30 minutes, then I would suggest if you can do 50 RPMs, rotations per minute, 50, as long as you can do it steady, on a steady pace of 50 RPMs or 40 RPMs for 30 minutes, and that's your initial pace. After a month of doing it, it becomes a little bit easier for you because you're becoming more conditioned. So maybe you can make it 45, and then 50, and then 60, and then 70, and then 80, and maybe you'll reach 90. If you reach 90, great. You don't need to go higher than that. And if you can't, and you can only do 70, that's still better than 50, and they'll still be okay. So that's kind of our secret. So in our, to just emphasize on mobility, we have our, this is pre-COVID. It's about 700 Parkinson patients we host in our city, and we emphasize. It's really quite neat. Okay, almost done. Lesson 4, patients with Parkinson's want to be engaged. So some of them show that the biggest tip we've ever given them is go to Fox Trial Finder, volunteer, Parkinson.org, or the support group, join a support group. So don't underestimate the patients coming in. Certainly education is king. And so that's the first part, is educate them what they need to do to advocate for themselves. And some of them may be willing to do more, and the next step is joining a support group. And then they may be willing to do more and look into maybe some clinical trials, Fox Trial Finder and Parkinson.org. Also, they might be able to do that. And then they might volunteer for other things. So it takes one step at a time. I think if you ask them to volunteer immediately, that might be too much, but it's baby steps as well, like anything else. So the other thing is, if you look at some of these low protein diet, they're getting smaller numbers now. Parkinson.org, pill alarm, low protein diet. I think what they're trying to do is trying to avoid motor fluctuations. There are papers after papers. This one is looking at nearly 200 more advanced Parkinson patients. What is the most bothersome feature of Parkinson's to you? And number one that shows up, fluctuating response to motor to medications. And then a similar study on nearly 100 Parkinson patients, more earlier stage, top 15 is still fluctuation in response to medication, even earlier Parkinson patients. So it still remains relevant. And that's why low protein diet, getting a pill alarm are things that keep us regular and less fluctuating. If you look at this, some said fiber, prunes, water are the most important tips. So this is one of the things that we can actually make a difference on. It's not too difficult to treat if you really put your effort into it, at least for the most part. There will always be some exceptions, of course. So always check for constipation. Again, if you look at studies on what are the most bothersome symptoms for you, unmet needs in Parkinson patients, look at this. Constipation is number 2, only to fatigue. And fatigue is a little bit difficult to treat, but constipation, you have fiber, you have water, you have exercise, you have Metamucil, benefiber, and you have Miralax or fleets and stuff if it comes to that, right? Fatigue is a bit more difficult. Okay, almost home stretch. Parkinson's is such an individual illness. And if you can see here, there are some patients who said, massage was the single best tip I got. Speaking louder, getting a platform walker, getting a dog. Oh, having silk pajamas at night so I can turn over. That was the best tip I've ever gotten. So Parkinson's disease affects so many things. So you have the condition here, concrete conditions, apathy, nocturnal akinesia is difficulty turning in bed at night. Hypophonia is soft speech. Truncal dystonia is getting curvature in your spine and pain. So these are concrete conditions. And the opposite end of the graph are the creative solutions. That's why they're a bit curved. I asked the patient to, I don't have a good treatment for apathy. You're not depressed, but you're apathetic. You have you have this blah feeling, but not sad feeling. I said, why don't you get a dog? Maybe the dog, you require some responsibility in caring for a dog, but it gives you unconditional feedback, unconditional love. So maybe it might be a good match. And he brings this dog with him whenever he comes to clinic, and said it's the best thing you've ever given me, more than levodopa. This dog keeps me alive. And then who knew that the silk pajamas that I prescribed was the one who made him sleep better in bed and be less insecure about bedtime. And one, loved her speech therapist and thinks the world of her. And the fact that she could communicate is like the best thing that happened. Platform walker. So this is an example of a platform walker where there are armrests. So they're higher, they're taller, and they have this armrest in there. It keeps the body straight, whereas all the other walkers are a bit low to the ground, and then you accentuate the curvature in Parkinson's disease. So this curvature in the spine in Parkinson's is in part dystonia. And the cool thing, one of the few cool things about dystonia, is you can trick the brain to straighten itself to some extent. And a platform walker does that. And then acupuncture, massage might help with pain for a lot of patients. So be creative in certain ways. You never know. Parkinson's is such an individual illness, and one little thing could make a big difference in a patient. So that's really it. I'm gonna boil it down to 4 conclusions. One is the most relevant non-pharmacological treatments that I learned from my little survey here are the ones that try to improve mobility, walking, and freezing. Those are like really, it hits the nail on the head, and patients really like that if the trick is found. A lot of patients want to learn and be engaged. They want to do more. And so don't miss that as part of your kind of visit counseling with your patients. I am so happy that the importance of exercise is finally gaining traction. It is no longer voodoo science. We have more data behind it. Any exercise works. Although we believe, of course, that very biased, that our exercise brand is a little bit better. But regardless, any exercise is really going to be good exercise. And then the last is Parkinson's is such an individual illness. Um, and the most consistently bothersome symptoms are gait imbalance, inconsistent response to medication, and non-motor complications. But as to ways, the percentages of these, it's all different from one person to another. So I think that is it for me. Um, I go give these talks, but really the one who stays behind and does all the work is my team of world-class clinicians. Really fortunate to have them as part of my second family, and I couldn't be luckier having this group of people. So hopefully you found some
Yeah.
tips from this, and thank you so much. I know I ran over a little. I got carried away
That's
with
all
my
good.
talk.
No, perfect. I think it was great. You really were very comprehensive, really thinking outside the box, which is what we like to do. Very holistic, really thinking about, listening to patients and getting that feedback, sort of teaching each other,
Yeah.
what makes a difference for patients. And I think there's even in the chat been a lot about sharing ideas amongst patients. One interesting thought, Hubert, with this forced exercise protocol with the person in front of you, and you show this group of people biking together.
Yes.
So much of my interest and passion these days has been about connection to each other as people. What do you think is playing in? I know that there is this sort of protocol that you've developed now from that,
Yes.
trying to take that home, and I think it's been
Mhm.
great to clarify that. And we can post that as well if you have any links. That your specific prescription, how people can
Yeah.
take this. What do you think the human connection is, though, with having that person in front of you, having the group experience?
Oh yeah, I think it's great, and certainly at the minimum, it makes people want to do the exercise. So I'm always asked this question. So doc, what's the best form of exercise? And of course, I know in my biased opinion what's the best form of exercise, but I hold back on saying that. And I first tell them that the best form of exercise is the exercise that you actually do. Because if we give them, a Peloton bike and they don't use it and it just gathers dust, or it becomes a hanger of like uh, clothes and stuff like that, then it's not helping, right? And that connection makes them do the work, and just that like kind of serves the purpose already.
Absolutely.
And so if they say, well, I don't want the bike, I mean, then I'm not going to force my 90 RPM low resistance forced velocity exercise. If they like the outdoors and brisk walking is kind of their thing, then that's great. I'm gonna make them do that.
Yeah.
But yeah, I think it's great, and the good thing about this, with it made us, like, even in COVID times, become more creative, and you could be a team doing the bike together, and even virtually. I think it's the potential for this is even more than how we envisioned it.
Absolutely.
Yeah.
Yeah, I think we do have to think outside the box during COVID to try to connect people, and
Yeah.
maybe having little mini group challenges about the thing. But I think the apathy strategies of getting together with people, and I love the dog idea too. I think that's
Yeah.
amazing. Hubert, you've been so active in the Philippines trying to help with the work there. Can you teach us a little bit about that work in the last 5 minutes? And I think this group is very interested in global issues with Parkinson's patients or internationally, and I do want to give you a few minutes to highlight that. And
Yeah. Well,
and also how we can help, the cause internationally.
well, thank you. Thank you so much for bringing this to light. I mean, my interest is as much out of guilt as it is kind of really genuinely trying to help the Filipinos. As I mentioned in the beginning, I was, um, kind of planning to go back home, and then we didn't go home. And this is my new home. Philippines is still my other home. And so my wife and I, we felt very bad that, we're contributing to brain drain in the Philippines, and we're not giving back to the people who taught us and where we grew up. And so we tried to figure out ways on how to help. And so we started creating the Movement Disorder Society of the Philippines, and it's now a growing number of fellowship trained movement disorder specialists in the Philippines, which is great. I'm always training someone from the Philippines to go back home and do this. And then they're still a bit behind with regards to developing kind of the infrastructure for clinical trials. If, in order to be kind of part of the inner circle so that you're informed and you get access to the latest that's going on, you need the clinical trial infrastructure. And so we're now working on this so that the Philippine standard in all these clinical trial execution of protocols will be hopefully nearly identical to the Western standard, so that when there's a new drug that comes on board, it's not just Americans and Europeans getting this, and then everyone else from Asia and Africa and Latin America waiting for what works in Americans and Caucasians, and then hopefully it works for them too. Fortunately, for the most part, it does, but sometimes their dose is a little bit off, sometimes their side effect is a little bit different. So these drugs need to be, and trials, they need to be tested as well in a more global kind of network of clinical trial subjects. And then there's this one very mysterious illness that can only be, that is 99% found in one island in the Philippines, the island of Panay, which is a combination of Parkinson's disease and dystonia. It's called XDP, for X-linked dystonia Parkinsonism. It's so mysterious. It afflicts a lot of the residents in this one island, and we don't know why. What's in this island? It's devastating, perhaps even more devastating than Parkinson's, because it's like a double whammy of disorders. And we have organized really a concerted effort to kind of understand XDP, get a registry going so that everyone with XDP is kind of known. And so when we have clinical trials, we can get it up and running and stuff like that. It's even rarer than Huntington's disease, and therefore we need everybody we can get to be in the registry, so that when we have a promising therapy, we have a reasonable chance of getting this studied correctly. So those are the things that we do. I'm there every other year or so during the Philippine Neurological Association. And I speak, and we train fellows and residents and stuff like that. So yeah, we try our best. COVID-wise, we haven't been there yet, because Manila is in a lockdown, but it's a real lockdown compared to the lockdown we have here in America. It's like pseudo lockdown. There is no travel by air, land, or sea. And as you know, my parents both passed away from COVID, and we have yet to visit the country because we were not allowed. We're not allowed. So so it's been a little tough.
It's been a very stressful time for you, Hubert. My condolences again. Now that we're seeing each other, I know
thank you.
So, but I so thank you for your work and your continued, participation. I know it's been so stressful with your parents passing away during COVID, but we appreciate you joining our group today and giving
my pleasure.
hope and activism. And I think all of what you said is exactly what we're all about. Exercise, I think, trying to connect with people, the empowerment through education, all of these things, connecting with a support group. I love that your graphics, and I think people will be continuing to
Yeah.
watch this, digest, and
just for you, I spent a lot of time in this. So
that is so
I,
sweet. Oh my gosh, I didn't know that. Okay, well, they're gorgeous. I love your the message. So beautiful. And we'll share this widely, and hopefully we'll get everyone doing the prescription of your exercise, because I think it's so key. And people feedback to Hubert. And then also, Hubert, if there's any links that you want to give us for the registry for the X-linked Parkinson's stuff, we can definitely spread this. This is the Movement Disorder Alliance. So as well as, not just Parkinson's, but it's PMD Alliance. So there's other people as well who may connect. So we'll share all of your information that you're willing to share with us.
Great.
Thank you so much for your time. I know it's
thank you.
Thanks,
tough, guys, and thanks for the condolences. We carry on the mission. I just try to make them proud of what I do, and so yeah, it's 4 months ago, so it's a little bit better now, so it's good.
But we appreciate that you didn't go into music or become you're teaching regardless, so I think you're going to be very proud. So love you, Hubert, and your work. And
thanks.
All right.
Yes.
Thanks. Bye.
We always share our gratitude with a goodbye wave, so you can everyone turn on your camera, put it in gallery view, and Dr. Fernandez, you can look out at all the folks that you helped today.
That's so sweet. Oh my gosh, this made my day. Thank you so much.
All right, everyone. Thank you again. Have a great day.